Hi, welcome for everybody to join us in this series of lectures in cardiovascular disease for medical students. This is the second lecture of cardiomyopathy. Now come to the hypertrophic cardiomyopathy. First lecture discussed dilated cardiomyopathy. In hypertrophic cardiomyopathy, look to the septum is the hypertrophied, thickened in proportion to the free wall. May also be sometimes free wall is thickened. So the occur in the 0.2, 0.002, 0.2% hypertrophy and non-dilated LV. In the absence of the other disease, as we said, aortic stenosis and hypertensive heart disease, athletic heart, small LV cavity, left ventricle, asymmetrical septal hypertrophy, we see systolic anterior motion of mitral leaflet, which is called SAM movement. This is thickened septum and sees that the SAM movement with obstructions and small cavity of the left ventricle. So it's idiopathic. It's called idiopathic hypertrophic subaortic stenosis, or sometimes idiopathic obstructive cardiomyopathy, HOCM, if there is obstruction. This is a picture we discussed in a previous lecture. This is the septum asymmetrical this is the most common. Why that in the even free wall involvement, this is the apical. The last two is the least common. This is the most common form of cardiomyopathy with a prevalence of 1 in 500. Please pay attention. This is come in your textbooks in last editions. I think this means that this is the most common form in the young adult. As we said in previous lecture, dilated cardiomyopathy is the most common in all age group, children, adult, young adult. But this is most probably in young adult is the most common. Approximately really 100 in the 10,000. It is characterized by inappropriate and elaborate left ventricular hypertrophy with malalignment of myocardial fibers and myocardial fibrosis. So hypertrophic cardiomyopathy is a genetic disease. Other name, idiopathic hypertrophic subaortic stenosis, hypertrophic obstructive cardiom if there is obstruction, sometimes divided obstructive, non-obstructive. Characteristics of this hypertrophic cardiom, hypertrophy, mainly septal versus to the free wall, and which is proportion 1 in 3. Abnormal diastolic filling, hypercontracting. In reverse to the dilated cardiomyopathy, hypocontracting myocardium. Primarily is a diastolic dysfunction. Systolic function is preserved. Disease which must be differentiated from hypertrophic cardiomyopathy are amyloidosis, hypertensive heart disease, aortic stenosis, athletic heart. So in the pathogenesis, in most patients, it is due single point mutation in one of the genes that encodes sarcomeric contractile protein. There is 3 common types. Beta-myosin heavy chain mutation usually associated with the elaborate left ventricular hypertrophy, most septal. Troponin mutations are associated with little and sometimes even no hypertrophy, but marked myocardial fiber disarray. This associated with exercise-induced hypotension and high risk of sudden cardiac death. While the third type, myosin binding protein C mutation, tend to present late in life and are often associated with the hypertension and arrhythmias. The first one is most common. So it is most cases a familial, autosomal dominant. Several gene mutation as we discussed the 3 common types. We will find the second artery next in frequency. And these three genes account for about 8% of all cases of cardiomyopathy. These genes mutation mainly, as we said, affect protein sarcomere. Clinically, hypertrophic cardiomyopathy, due to the decreased compliance, decreased chamber size, decreased ventricular size, and diastolic filling. This is the pathophysiology of the hypertrophic cardiomyopathy. In 25% have obstruction to the ventricular outflow with the systolic ejection murmur. Focal cardiac ischemia and angina is and the major problems are atrial fibrillation, arrhythmia, mainly atrial fibrillation, neural thrombus formation, embolization, and infective endocarditis in some cases, although it's not common. One of the most common causes of sudden cardiac death in young athletes. And if we look to that, this is this diastole and during systole. Is the systole, the size is the narrow, septum is thickened, and this is what called some movement, anterior wall motions of that the mitral valve with that the ejection of blood into the left atrium and due to the mitral regurgitation. Look how the left atrium is the big and enlarged. Really both atria will find sometimes, but left atrium is mainly. So hypertrophic cardiomyopathy, hypertrophy of ventricle, and then 95% of cases. This array of myofibril, 100%. Volume reduction in 90% of the ventricle, really. Endocardial thickening of LV in the 75. Mitral valve leaflet thickening, 75% of patients. Dilated atria, 100% of patients. Abnormal intramural thrombus in 50%. There is a high risk of thrombus. Look to that the septum and the growth pattern septum, how it is thickened and asymmetrical. And this is long axis view in the echocardiography thickening, and this is anterior leaflet. If it's moving here in the systole, lead to the obstruction of left ventricular outflow obstruction. So this is what I mean by disarray. Microscopical examination of the heart look to that the myofibril is a parallel with these nuclei, while in the cardiomyopathy, this is the pattern of the disarray. This is really underlying causes of the arrhythmias, and this is the disarray in the under microscope. So the main abnormality of the heart in hypertrophic is excessive thickening of the muscle. Thickening began during early adolescence and stop when the growth has finished, really, in 20s. The hypertrophy is the greatest in a septum wall, separating your left and right ventricle in proportion to that the free wall. The muscle thickening in this region may be sufficient to narrow left ventricular outflow and lead to that what called hypertrophic obstruction. Really, if thickening very thick of the septum, so that during systolic ejection of blood, it might be obstructed. Give ejection murmur and give mitral regurgitation in a clinical examination. In the thickened, stiff left systolic function is well preserved, but diastolic function is compromised. Thickening of the septum may result in left ventricular outflow obstruction and abnormal motion of mitral valve leaflet, which is called some movement, and resulting in the mitral regurgitation. We find this is asymmetrical hyper is the more common type, 65%, while this is and the rarest apical, really. A clinical manifestation of hypertrophic cardiomyopathy may be asymptomatic, only echo finding, and may be presented with chest pain due to the thickened myocardium, and during exertion it needs more oxygen, and there is disproportion between supply and need presented with inguinal pain. Maybe syncope, pre-syncope, and maybe dyspnea, sign of heart failure. May be presented with the sudden cardiac death, and we say that one of the common causes of sudden cardiac death in the young adult, athletes, and even children. So effort-related symptoms during exercise or shortly after, angina, breathlessness, arrhythmias, or sudden cardiac death, these are dominant clinical presentation. Maybe asymptomatic echo finding. If symptomatic, as we said, weakness, fatigue, dyspnea, and effort because of inability to significantly increase cardiac output with exertion in 95%, palpitation, chest pain, angina, factors due to the myocardial ischemia in 75%, dizziness, pre-syncope, syncope, and sudden cardiac death, also a problem. The pulse can be brisk, early systolic ejection of the blood from the ventricle, a prominent left ventricular lift, double apical impulse. Peak because of ejection is interrupted by septal obstruction. The first and second heart sounds are normal. Systolic ejection click common. The systolic murmur is ejected in types and of medium intensity. Is heard maximally left sternal border and at the apex. Murmur may be increased shortly after exercise, and after exercise is discontinued. This is what called Valsalva's maneuver. ECG, left ventricular hypertrophy, ST segment depression, T-wave inversion, sign of Wolff-Parkinson-White syndrome sometimes. Rhythm disturbance are defined by Holter monitoring. X-ray, chest, mild cardiomegaly with a prominent of the left ventricle. This is echo finding, and this is the M-mode, and this is the 2 mode, and this is the septum hypertrophy and some movement, how the left atrium is enlarged too. And the hypertrophic cardiomyopathy, echocardiography, if you look at it, you will see that the septum hypertrophy more than 2 cm, even more, and that the normally 1.2, 2.3 cm, the septums. And the mitral valve is moving anteriorly for obstruction, and hypertrophy septum in systolic and left atrium enlarged too. And the prognosis of HOCM really is unpredictable, maybe asymptomatic. Patient may remain stable for years. Some patients progress to the chronic heart failure, whereas others are at risk for the sudden cardiac death from the arrhythmias mainly. Please look to the 3 points important. Firstly, competitive in management, sport, and strenuous physical activity should be prohibited because most of sudden cardiac death occur during or immediately after vigorous physical exertion, especially in adolescents and young adult athletes. Digitalis or aggressive diuresis contraindication in most patients because of potential increase in LV outflow obstruction and vasodilatation. Thirdly, beta adrenergic, this is good news. Thirdly, beta adrenergic blocking agent, propranolol mainly, atenolol, and calcium channel blocker, mainly verapamil or nifedipine, may be useful in diminishing ventricular outflow tract obstruction, modifying ventricular hypertrophy, and improving ventricular function. Patients with documented arrhythmias or history of unexplained syncope should be treated aggressively, usually with implantable cardioverter defibrillator ICD that have high risk of the sudden cardiac death. Prevention of sudden cardiac death with implantable defibrillator is very effective. Surgery in very limited patients by ventricular septal myotomy, disabling angina, syncope associated with left ventricular outflow obstruction, or mitral valve replacement sometimes if obstruction cannot be alleviated. Sometimes Sometimes we do artificial infarction by injection alcohol. This is the septal myotomy surgery to relieve the obstruction. Sometimes do by the septal injection of embolization and do infarction. And in very limited cases we use. Another types of cardiomyopathy, which is the least common, the rare types, the restrictive cardiomyopathy, one of least common cardiomyopathy. Ventricular volume and wall thickness is normal. Decreased volume of both ventricle, mostly idiopathic, sometimes familial, and usually associated with some systemic disorder like amyloidosis, sarcoidosis, hemochromatosis, scleroderma, and carcinoid. And this is the look to that the rigid left ventricular wall and the poorly ventricle compliance is a major abnormality in a restrictive cardiomyopathy, and its inadequate filling of ventricle cavities occur during diastole, so result in diastolic dysfunction, but in the progress of disease might be combined with the systolic dysfunction. Hallmark abnormal diastolic function, rigid ventricular wall with impaired ventricular filling, bear some functional resemblance to the constrictive pericarditis we'll discuss in the lecture of the pericarditis. So restrictive cardiomyopathy in a short impair of diastolic function, primary decrease in the compliance, impaired diastolic filling. Least common form of cardiomyopathy, ventricle approximately normal size, systolic function unaffected firstly, lastly it may be affected, bilateral dilatation, bilateral atrial dilatation is commonly seen. Myocardial fibrosis, as we see in amyloidosis, sarcoidosis, radiation due to malignancies, and the metastatic carcinoma, sarcoid granuloma, any factors which increase the endomyocardial fibrosis. Treatment really not too much. No satisfactory medical therapy. Drug therapy must be used with caution when sign of heart failure exist. Use of diuretic can result in a clinical improvement. Vasodilator may decrease filling pressure. Calcium channel blocker may improve diastolic compliance. Digitalis and other inotropes agents are not indicated. There's the last types of the arrhythmogenic right ventricular cardioma, right ventricular dysplasia, some text, oxide, associated with right-sided heart failure, various rhythm disturbance, ventricular tachycardia is the most common, right ventricular thinning due to the loss of myocyte, one of the most common cause of the sudden cardiac death in young adult. Few points about cardiac tumor because the ending this lecture. Primary cardiac tumor is rare, while secondary is the most common. This is the list of benign and malignant tumors. The most common benign tumor, most common is the atrial myxoma, our left atrial myxoma, is the most common primary tumor of heart, mostly within atria, 90% could be other side. Left to right is the prevalence 4-1, mostly in the left, could be right, benign, and 10% may be malignant. Almost always single neoplasm. 100% familial, what called Carney syndrome. Clinically, ball valve obstruction like mitral valve stenosis. Constitutional symptoms, fever, high SR, and so on. Embolization is a risk. Rhabdomyoma, most common cardiac tumor in children, often diagnosed within first year of life. Obstruction disease, and in follow-up it will disappear after half a year or 1 year. While the non-cardiac neoplasm, we say the secondary neoplasm in the heart is the most common, as the commonest than primary. Most common are metastases from lung, breast, melanoma, and leukemia and lymphoma. Thank you for the participation.